Thank you everyone for joining the OTAC clinical case webinars. Tonight's topic is about side effects related to OAT, and today we have Dr. Richard Hallinan, who's a senior staff specialist at Drug Health Services in Southwestern Sydney Local Health District, along with Associate Professor Shilpi Ajwani from the Sydney Dental Hospital and Oral Health Services, Sydney Local Health District, and Dr. Shivani Chandra, who is a senior dental officer at Sydney Local Health District. Before we begin, I'd like to acknowledge the traditional custodians of the country on the lands on which we meet and recognize their continuing connection to land, waters, and culture, and also pay our respects to elders past, present, and emerging. So just some registrations for tonight. We have a big show up from the metropolitan registrants, but also people from all over. We have someone from Western Australia, Victoria, Queensland, and a lot of people from Southeastern Sydney Local Health District as well. But thank you everyone for coming. And also people from a lot of different roles. We have representation from every role, and we had about 98 people registered for tonight. As a reminder, the webinars will be made available online as a recording, and the slides will also be available on the OTAC website. So the webinars are a monthly case-based webinar from 6 to 7 p.m. on a Tuesday. For those who participate, we will send a certificate that you can use for CPD points, and we'll email the certificate tomorrow. And just a little reminder that we do have OTAC scholarships, which are open to unaccredited general practitioners and nurse practitioners who work in private work settings in regional, rural, and metropolitan areas. And there's more information on the OTAC website under the scholarships tab. And then just some quick housekeeping. Please keep yourselves on mute unless you'd like to ask a question. We encourage you to type any questions that you have in the chat, and we can ask them along the presentation. The webinars are recorded, so please don't reveal any identifying information. And please be considerate and polite to your colleagues as well as the presenters. And if you think you may have a conflict of interest, please sign out from the webinars. And I'll turn it over to Dr. Richard Hallinan. Thank you.
Thank you, Jessica. Thanks for the invitation to speak. I see a few familiar names in the attendance list. So some of you, Peter McCall, John Smart, Ron Strauss, will have heard some of this before in previous seminars. So the topic as proposed was OTP or OAT side effects. And even that title itself may be sometimes unduly presumptive. It's not quite as easy as it might appear to determine what is and what is not necessarily a side effect. Are symptoms that people have during treatment always side effects is one of the questions that we ask. There's the question, why do we even care? And I'd say up front that there are fundamentally three reasons, which I hope you'll see emerging also in the little case studies that we've got. Now, the first one is about quality of life, naturally. And that quality of life issue may be not just for the person themselves, but also their family. The second one is, of course, long-term health. If there are side effects or related to medication that might imperil long-term health in various ways, obviously we need to think about that long-term view. And then the third issue is that side effects potentially can affect treatment adherence and cause people to drop out of treatment altogether. So, a previous sort of subheading for topics, the seminar that we did on these topics, we had the subheading separating fact and fiction, which I hope we'll do. And should we be bothered? And I think we should be bothered, but the next question is, how should we be bothered? Next slide. Okay. Now, Tom is a 20-year-old man who's recently joined methadone maintenance treatment out of jail. So he came to the clinic about 2 months prior on this dose of 50 milligrams of methadone a day. He'd had a 7-year history of heroin use, repeated incarcerations. He had been injecting drugs over the years, but luckily didn't get any chronic viral illness from that. He'd wandered in and out of methadone treatment and buprenorphine once, but didn't stay. On one occasion, Tom was sent for medical review after having missed quite a lot of days. He's at a public clinic at this point, and he's supposed to be attending every day. And specific questions about side effects revealed mild sweating, moderate constipation, and some erectile dysfunction. Now, I'd ask the question, now, how do we actually ask about side effects? You could say to this guy, do you have any side effects? And he may well say, well, what's a side effect? Or you say, oh, no, should be right. But if you specifically ask about sweating, he may well say, oh, yeah, I sweat like a pig, doc. If you ask about constipation, he may not know what that means, but if you ask, when he goes to the toilet and opens his bowels, he may say, oh, yeah, no problem, I go. And if you ask how often, he might say, oh, almost every week. So it's about how you ask, of course, and in what detail you go. Asking about erectile dysfunction might seem a little bit odd. Everybody's got their own way of asking about side effects like sexual dysfunction. My present favourite is just to ask, how are things in the bedroom department? And at least in native English speakers, most people seem to understand what that means. And if they need a bit of prompting, you then say, well, some people actually find difficulties with their sex lives on the treatment, even off the treatment. But how's that going for you? Next slide. 2 weeks later, he sent for medical review. Again, he's missed 7 days this time, and he simply said it's stress at home. And on further inquiry, we find that his partner and mother of his 3 children is angry at him and actually thrown him out of her home. So he's homeless and he's sleeping in the car. She suspected he's seeing another woman because he's not performing in bed, and she thinks he must find her ugly and doesn't love her anymore. And obviously, this is a big issue in the relationship, and it's a big issue for his treatment adherence as well. And in particular inquiry, we discovered that he has low sexual desire, that he's having erectile dysfunction, and he's also having difficulty achieving orgasm. And if you are used to taking a sexual health and sexual function history, you'll recognise that it's important to ask about at least all those 3 things. And these problems actually got better when he used heroin. Now, I'm going to leave the discussion of this case till a little bit later, but I want to have the next slide. Because when we talk about side effects of treatment, we have to think about what life was like before treatment. And an old study of heroin users before and after treatment, one of the golden oldies, gives them indications there on a 5-point scale of the severity of the problems listed there, whether they got better or worse during treatment, and how that varied depending on the dose that they were on. And essentially, you see that for most of those symptoms, I'll call them, not necessarily side effects, the symptoms got better for most people by something like a 0.5 to 1 point out of 5. And in the cases that were marked with an asterisk, that was statistically significant. Some of the things, of course, you wouldn't call symptoms, like prostitution and so on, but those things got better. Craving clearly better, heroin use clearly less. So here's the suggestion that, in fact, some of the things that we might put down, the side effects like nausea and vomiting, aches and pains, sexual dysfunction and constipation, actually might have been there before the person entered the treatment. They could be related to opioid dependence, the opioid dependent state. Note constipation not actually getting any worse during treatment. Let's have the next slide. There's a particular instance of this that I wanted to show you, an American study from 19 years ago showing how the variability of menstrual cycle length as a measure of the instability of menstrual cycle tended to improve over the duration in methadone treatment of this fairly large number of women. So things can improve in the treatment. They don't always get worse. Let's go on to the next slide. Previous research of symptoms in opioid substitution treatment, opioid agonist treatment, have some limitations. Obviously, randomized controlled trials have got their inbuilt limitations, and they generally only reported adverse events. But where there were treatment-associated symptoms, they tended to be this list, and these are indeed the takeaways. They're the most common ones that we probably should be asking about. Where buprenorphine and methadone have been combined, there's generally not been a great deal of difference. And the prevalence of those symptoms relatively low in the randomized controls, but if you do cross-sectional studies, symptoms are much more common. And I will say that Adam Winstock, who did some very elegant and very inexpensive research in southwestern Sydney, found that there were high rates of report of symptoms and desire for help with symptoms in the opioid-treated population down there. And people were not necessarily getting treatment or having their symptoms or side effects addressed. Next slide. So this is relating to a study that we did out of RPA and in southwestern Sydney. And it was originally intended to be a study of side effects, but we quickly realised that it was unduly presumptive to talk about side effects in people who were on methadone and buprenorphine treatment. And so we instead recast it as looking at symptom profiles. And this was a survey of men and women on methadone and buprenorphine with opioid-using people who were not on treatment, and also healthy people who were not using opioids at all. So there are 4 study groups. We used a 22-item symptom checklist derived from a whole lot of previous studies, some of which I'll show you later of that checklist, and also 5 validated scales. So one was the PACS, which is a constipation scale, which is validated, the Athens Insomnia Scale, the Epworth Daytime Sleepiness Scale, the Arizona Sexual Experiences Scale. Important thing about the Arizona was it's for men and women, gay and straight, single and partnered, and nobody had used that for this kind of context before. And the Hospital Anxiety Depression Scale also data on people's substance use, self-report demographic data. We wanted to crunch all of this together and see if we could tease out what the symptoms were and what they were associated with, if not caused by. Next slide. So here's some of the results from the symptoms checklist. It's a busy slide, of course. Is the symptom nominated on the left, the percentage of people who had it at least sometimes in the buprenorphine, methadone, other opioid-using groups, and in the healthy reference group. And we did some comparisons statistically. We didn't compare the healthy reference group statistically because, of course, we didn't expect them to be anything comparable to the people who are using opioids. That's the first thing. But we did compare the buprenorphine and methadone group together, that is, those people on what we were calling OST then, OAT now, with the people not in treatment. And that's the first column of P figures that you see there. And the first standout thing is that a lot of those symptoms were clearly worse in the people who are not in treatment. So this is quite similar to what Garbutt and Goldstein were finding back then in 1972. So nausea and vomiting clearly much more frequent in the people who are not in treatment. Same with diarrhea. Weight gain was not significantly different between the people using opioids in treatment and not in treatment, but sweating was probably statistically worse in those people who were still using opioids on the street. Itchy skin, similarly, coming in as worse or more common, more frequent in the people who were using opioids not in treatment. I mean, we all know the expression being on the scratch when you're using heroin, an indication of that. There were very few differences between the buprenorphine and methadone group, and that's the column on the right. So you see weight gain significantly more common in the methadone group than the buprenorphine group, and sweating also worse in the methadone group. So that's statistically significant. The difference seems clinically important. And vomiting, depending on what P figure, what alpha you choose, also significantly different between methadone and buprenorphine. So let's go to the next slide. Just a few more items on that symptom checklist, and generally again, the palpitations and the heart racing was much more common on the people who are not in treatment. But passing out was not different between methadone and buprenorphine, and actually less common in people on treatment than people not in treatment. So much for the symptom checklist. Let's go to those validated questionnaires now for particular symptoms. Next slide. So insomnia, top row, daytime sleepiness, sexual function, constipation on the PAC-SIM, that validated score. And the standout facts here are that daytime sleepiness was significantly worse in those people not on treatment. So we may be worried that our people on methadone, the 23% of them have excessive daytime sleepiness, but it's worse if you're not on treatment, more common at any rate. There was a trend towards significance of daytime sleepiness being less severe if you're on buprenorphine, but not quite significant. And constipation also a trend towards it being significantly different between the people on treatment and not on treatment, but surprisingly not large differences. The severity of constipation seemed to be a bit worse with methadone. So there just aren't really huge differences coming out here. So we did some multivariable analyses to try and tease out what factors might be significant. And we go to the next slide. And comparing, before we do that, is methadone or buprenorphine dose significantly related to any of these symptoms? So the more methadone, the more constipation, and so on. And in fact, the correlation coefficients for opioid dose are very low. These are very weak correlations with dose all around. So it's not giving us a great deal of assurance that changing the dose is necessarily going to make these various symptoms go away. Next slide.
Richard, we have a question asking,
Yep.
Is daytime sleepiness a dose-related effect with methadone?
Okay, so you go to Epworth there, and that's the bottom row, and you look at the Spearman's rank correlation coefficient, and you find statistically no, not related, at least in a cross-sectional study. Now, that doesn't mean that in any one person a higher dose may not lead to a greater degree of drowsiness, but across the population, you're not seeing it as a significant factor. Next slide. Onto those multivariable models. Now, let's look at vomiting first, which we thought was like the severe end of the nausea vomiting spectrum. And it was significantly more common in people who are not in treatment. And this is surviving multivariable analyses. These are the ones that pop out at the end when you put them all through the sausage grinder of multivariable analysis. Anxiety somewhat increasing the odds of vomiting. Constipation increasing the odds of vomiting highly significantly. And that odds ratio, you see there 1.04, is per point of the PAC-SIM score, and the score is out of 70. So if the difference, if in constipation is 30 on that scale, that's doubling the odds of constipation. The odds of constipation causing vomiting. And cannabis use also doubled the odds of a person vomiting. Now, we don't have to go into the question of cannabinoid hyperemesis here, just noting that for the record. So a couple of traction points there. If somebody's vomiting, what can you look at? You can potentially look at the cannabis use and their constipation, and they could potentially be therapeutic points of access. Let's go to the next slide for the next major symptom, fatigue. Now, so fatigue, if you didn't notice on the previous slides, was very common, and it was also very common in the healthy controls. The things that were connected to it in the multivariable analysis in the opioid users, this is all opioid users, by the way, whether in treatment or not. So whether you're in treatment or not made no difference to the odds of fatigue, but insomnia did, doubling the odds of fatigue, as did depression, more than doubling the odds of fatigue. And again, constipation coming in very strongly associated with fatigue. That was a bit of a surprise for us. So we've got now constipation associated with higher risk of vomiting and now higher risk of fatigue. Let's go to the next slide. Insomnia itself, quite obviously very marked increases in the odds of insomnia if the person was anxious or depressed. That's almost axiomatic. Insomnia is a symptom of each of those conditions. Cannabis use also coming in significant as roughly doubling the odds of insomnia. Now, whether that's cause or effect is, like with a lot of these things, is a question that we have to ask. Is cannabis use causing insomnia, or is cannabis use perhaps a self-medication of insomnia? But another traction point when we start looking at how to treat. Next slide. Next major symptom, daytime sleepiness. And so we had buprenorphine in the multivariable analysis coming through associated with lower odds of daytime sleepiness. So again, something suggestive for us without being conclusive. I think the P figure speaks volumes for depression, increasing the risk of daytime sleepiness. I think we can all imagine why that might be the case. So among the things that are happening here, if you've got a patient who's got depression and who's got anxiety, to be asking about daytime sleepiness is probably an important thing to be doing. Next slide. Sexual dysfunction, and we found no significant difference between methadone and buprenorphine and the non-opioid users. We found sexual dysfunction globally was had twice the odds in women than men, and both anxiety and depression, and particularly depression, associated with higher odds of sexual dysfunction, and tobacco and packet years approaching significance there with the severe alpha that we use. Now, the mechanism we would suspect could well be, in the case of men anyway, erectile dysfunction related to exposure to tobacco smoke over the years. So let's go to the next slide and just pull this together. Lessons from this study that methadone and buprenorphine are actually quite similar, except for constipation, sleepiness, vomiting, sweating, and they're actually reasonably important symptoms. So there could be a preference for buprenorphine if these symptoms are significant, but not on the basis of this for the other hosts of symptoms. In general, male and female symptom profiles were similar, except for sexual dysfunction. Generally, the people who are receiving opioid agonist treatment were less symptomatic, significantly so than those people in treatment. And that was particularly so for the symptoms listed there. So if you're not in treatment, the odds of you having nausea, vomiting, diarrhea, appetite, weight loss, itchy skin and passing out were substantially higher. We found that anxiety, depression, and constipation were strongly associated with other symptoms. It is important to ask about these symptoms, and I've asked rhetorically here, how do you ask? And I've given you an indication before. Don't just say, have you got any side effects? Be specific. And use common language. Don't assume that people understand what the medical terminology is. Let's go on. I think I've got 10 or 15 minutes left. So this is another case. We'll come back to Tom later. Trent's been on methadone for 15 years. He was previously heroin dependent. He hasn't used heroin for years now. He actually doesn't want to reduce his methadone at all. He likes his benzos. He's a very heavy cannabis smoker. He starts his day with brekkie cones, as they call it, before he comes to the clinic for his dose. He's also known for recurrent, witnessed, immediate severe vomiting shortly after the methadone dose, often losing the entire dose. This is a real person, and I used to see the complete and utter emesis happening in the garden bed outside my surgery. And we could be sure that he was losing the lot. It was a great inconvenience to him and to us. Now, luckily, because it was witnessed, we could supplement doses, and he would often, with the help of some metoclopramide or even some sublingual ondansetron, sip his dose over 60 to 90 minutes and keep it down. Or sometimes We just realised it wasn't going to happen, and we give him the dose to take home as a takeaway to sip gradually at home. Next slide. So we asked a few more questions. He is chronically constipated, bowels open less than once a week. He reports that coloxal center makes him sick with belly cramps, and he has a chronic cough, productive of phlegm, really vile phlegm, and you see it in the vomitus and especially in the mornings. So if I could open up to the room, does anybody have any suggestions about what's going on and how we might manage this? Anybody who wanted to comment could unmute or type in the chat. And I'm not going to put too much pressure on you. And we don't have that much time. But on the basis of what we've seen and working for first principles, being chronically constipated, having delayed gastric emptying, is surely going to increase the likelihood that you'll vomit, particularly if you get out of bed in the morning and you dump a whole lot of vile phlegm from your chest into your stomach as you get up just before you go to the clinic. And you move it on your way with a couple of cones of cannabis. But coloxal senna he doesn't use because it causes belly cramps. An approach to this patient would be perhaps three-pronged. One would be to deal with his constipation as effectively as you can. In general, we have a recommendation to avoid irritant laxatives in people who are on opioids for an obvious reason. I mean, in a person who's got a bowel that's, as it were, clamped down, the last thing what he'd do is drop a depth charge down there. Luminal, that is osmotic agents, are preferred. Movicol, thankfully, subsidised. Lactulose, perhaps symptomatically preferred by those people who can afford it. And of course, fibre and so on are really the mainstay. I would co-formulate methadone with something like Movicol if I had my way. You do have to be a little bit careful because some people can, depending on the dose, oscillate between constipation and diarrhea. By the time they've loaded up with enough Movicol to shift a constipation of 7 days, you can just imagine what the transit time is for a person who's only opening their bowels once a week. By the time they get on top of it, they may then have loose stools, but really worth attention. We can suggest to him that the cannabis itself could be contributing to his vomiting if it's hydremesis related to cannabis. The only real diagnostic test of that is response to abstinence and reinstatement of the symptom if you reinstate the drug. This guy didn't have any bathing or showering to suggest the full syndrome, but it's worth proposing it to him. And anything else you can do for his chronic cough, including addressing tobacco smoking, might be things to help here. Let's go on to the next slide. Next. Now here's Fafner, the stonemason, at least dry stone walls. At age 32, he started methadone. He'd had a back injury from his work and he'd started heroin use, treated his back pain with heroin as you do. And he actually reduced his methadone and came off treatment for a couple of years, but relapsed and he had to start the treatment again. So now at age 41, several attempts at failed reductions. He's and sometimes at the insistence of his girlfriend, he's back on methadone. Let's go to the next slide. And his dose is up to 55 milligrams a day, and he's disclosed frustration with sexual dysfunction, low sexual desire, low energy, and what he described as hot flushes. He's also put on weight. He's got central obesity. He was examined. His visual fields are normal. He had normal hair distribution, testicular size. We've got some palmar erythema, a palpable smooth right lobe of the liver, so enlarged, but no spider nevi. What investigations might we institute here? Anybody can type in, but as we've only 10 minutes left, we could perhaps go to the next slide. So I think there's enough information here to check a testosterone level, the sexual dysfunction, and particularly the other symptoms that he's described. And we did it, and we found that an early morning collection was indeed not only below the reference range, but it was in the range where, if it was persistently at that level, you might consider androgen replacement. It was fatty liver on the ultrasound. He's got no chronic viral illness to affect his liver. Diet and exercise didn't normalize his testosterone. The second time it's measured at 3.7, so lower. And in view of his chronic low back pain, we performed bone density and found him to be, now, is that osteoporotic? I think it is. Let's go on to the next. I should have included the ranges there.
We did have two people in the chat, but we did go to the answer page, but someone said TFTs, testosterone, and someone else also said LFTs.
Yeah, so good, right on the money. That's what we did. Let's have the next slide. So a few other studies were done, including iron studies and an MRI of the pituitary fossa. And those who've seen previous seminars will know that classic exclusions for hypogonadism are hemochromatosis and a pituitary adenoma. So it's important to make sure that that's not the case. Sorry, can we go back to the previous slide? I didn't remark on the FSH and LSH. Now, they're normal, and they shouldn't be normal. So in a person who's got a low testosterone, the FSH and the LH should be up there flogging the poor old testes to produce more testosterone. So this is what they call gonadotrophic hypogonadism. The problem is at the pituitary of the hypothalamus. Down a slide again. Okay, so he saw an endocrinologist. By the way, also vitamin D deficiency was identified. He was treated with sustanon injections, which were eventually ceased because he tended to get cranky and even a bit aggressive. He did better on Testogel. After 12 months, there was a two-month break from androgens to see if the problem had maybe resolved itself. This was suggested by the endocrinologist, but he remained clearly hypogonadal. So at this point, we've got an assumed diagnosis that it's got something to do with the opioids, because opioids would cause this kind of hypogonadism. And the blood tests are consistent with that. Let's go on to the next slide. And 6 months later, we're seeing improvements in the bone density. His weight fluctuating. He's actually separated from his partner, but he's married to a woman 20 years younger, and things are actually better in the bedroom department. And he's had some gradual methadone reductions, but he still complains of being uninterested in sex. So look, this is a real case. And you might be asking, was this androgen replacement subsidized by Medicare? And the answer is it would depend on the specialist that you consulted. If you found an endocrinologist who was prepared to say that this is an established pituitary disorder, then it might be, but or a sexual health physician, but otherwise not. Let's go to the next slide. There was a study of 92 patients on methadone and 3 other studies that are mentioned there that have identified osteopenia and osteoporosis in people on methadone treatment. Now, this first study was in Boston, and there was a high number of people who also had HIV, and proportion of people who were Black Americans, and so you can imagine that the issue of vitamin D deficiency was probably quite important there. So this is something to be on the lookout for. We haven't ourselves been doing generalized screening, as it were, for osteoporosis, but if there are predictors that might point you in that direction, this is one of those long-term health effects that we should be alert to. Next slide. How do you treat androgen deficiency? Well, you need to consider that obesity itself can contribute to androgen deficiency, and the things to be treated include obesity, grip strength, mood, and not necessarily always sexual dysfunction, because often that might get better for a week or a month or 2 months if you give somebody testosterone, but it is not necessarily persisting benefit. There is a risk of exacerbating sleep apnea with testosterone treatment, and there are possible effects on fertility. At least, though, if you go into this issue and you talk about the issues, people can make informed decisions about what they're going to do. Next slide. Back to the case of Tom. How do we manage his problem? Why is he using heroin? Well, there's less opioid effect. He's probably hanging out a bit, and when you're hanging out a bit, people do, quite often behave like bunny rabbits, according to the accounts that I've had from my patients. There are various things that might be done. It's possible to time a methadone dose to allow for sexual activity. It's really important to place this within the relationship, so there's discussion. It's possible to use Viagra or something like that to produce an artificial libido and to improve sexual dysfunction. And a transfer to buprenorphine may be helpful, and indeed in this case was. Let's go to the next slide. How does sexual dysfunction present in opioid pharmacotherapy? Often it doesn't present at all. If a person's not complaining about it because they've got low libido, it may not even be a symptom, but it may have effects on mood, relationship, as we've said, compliance or treatment adherence, opioid underdosing. Somebody staying on 30 milligrams where they should have been on 100 and still using heroin. So it's really important to ask about the bedroom department. We're almost at the last slide, I think. Okay, if you're going to manage it, you do need to look at all of these issues, which I won't go through, and check hormonal status if it's appropriate, and identify what effect it's having on their lives. There's a whole textbook in this, and a textbook chapter I can share with anybody who emails me and is interested. Next slide. The interventions I've already alluded to. Bear in mind that some SSRIs and other medications can probably also reduce sexual desire and function, so that needs to be looked at. For men, there are the Viagra class drugs and the things called cock rings. For women, it's a seminar in itself, which Leslie Yee gave to us about 10 years ago. A summary again I can send you. There is a pink Viagra for orgasmic problems, for arousal problems, and systematic oral contraceptives or topical estrogens do exist. For low libido, transdermal testosterone exists in Western Australia, apomorphine in Europe, but there's little evidence for DHEAS supplements. I think now the last slide. So these symptoms that we've described can be treatable or manageable. Dry mouth should be routinely addressed, and I'm sure our colleagues from the dental world will talk about that. The symptom of fatigue, I suggest, should point to insomnia, depression, constipation as possibly underlying this, and vomiting should lead you to consider cannabis use and constipation, as well as chronic bronchitis. Blurred vision, if it's a symptom, obviously you should have your eyes tested formally, and it's relevant to driving. Sweating was one of those prominent symptoms. We had used anticholinergics, so probanthine or propanthyline, and sometimes the non-sedative antihistamines with benefits for sweating. And we suggested strongly vigilance for daytime sleepiness in our people receiving opioid treatment and counselling around the associated risk. I think that's the end of my presentation. Should we slide down just to be sure? It is.
Yes, thank you, Richard. And thank you for being so on time. That was a very interesting presentation. If there are any questions, please feel free to put them in the chat. And if Richard isn't able to answer them by the end of the webinar, I can also email them to him, or you can email him, especially for some of the resources that he mentioned previously. But now we'll turn it over to Shilpi and Shivani from the Sydney Dental Hospital.
Thank you, Jessica. That was a really great presentation, Richard. I think we learned from the dental world quite a bit as well. And I think it's a really great segue because as Richard has highlighted, oral health does have an impact, is also impacted by the use of drugs as well as methadone treatment. And our presentation is just going to highlight some of the factors why this may be the case, as well as followed by a clinical case that Shivani will present that we have seen in our Canterbury Dental Clinic. Next slide. So as Richard covered, a fair bit of symptoms are related to the use of drugs, and they seem to impact the front end and the back end, apparently. So the front end is a big factor for us because there's a complex myriad of things happening. There is one, the use of psychotropic drugs if somebody's still on it. Same with somebody's on methadone, and also people who are consuming alcohol and other kind of recreational drugs and smoking. All that leads to a lot of problems and impact on oral health. There is both direct impact as well as indirect impact. The drug and alcohols negatively impact oral health by resulting in different oral conditions, mainly due to impact on salivary function. As Richard mentioned, xerostomia is a huge direct impact which has not only systemic implications, but direct oral implications as well. It results in increasing the risk of different dental diseases, but also fungal infections, mucosal infections as well. So it's really important to ask about oral health if you are considering doing a screening, overall screening of the patient. The other thing is that along with the dry mouth, there is a craving for sweet foods, especially people who are on methadone. There is evidence to suggest that they do crave a lot more sweeter things, but also they are more lethargic. There's lifestyle factors. They have difficulty getting out of bed. Their interest in their self-care is very low. Obviously, oral hygiene has a direct impact on that. A lot of them are not really able to consume the food that they should be eating, either because of teeth and vice versa. As we heard today, there is impact on osteoporosis, which also results in tooth loss, is related to tooth loss. So the systemic impact of methadone and other treatments also have a direct impact on oral health. Obviously, there is a correlation between smoking and oral health, and also compromised immune system. And last but not least, a lot of people have dental anxiety. Increased dental anxiety, increased dental phobia, and cost and access can also be an issue. So all these factors result in negligence in oral health, which results in oral diseases either progressing much faster than otherwise, or they may result in hospital presentation, acute presentations because of abscesses. Next slide, please. So I hope you're not eating or drinking anything at this point. The next few pictures are a bit graphic, but they are what we see in clinic today. So some of the impacts on substance use disorder is mainly dental caries, because dry mouth results in less bacteria getting flushed through the mouth, so they stay in the mouth longer, and that results in more acidic environment, which is very favorable for bacterial growth. There is periodontal disease, which is eating away the gums. And as Richard mentioned, a lot of them have vomiting. They have anxiety-related disorders, so they have parafunctional habits like grinding and bruxism, and that results in these weak teeth breaking down very quickly. A lot of them have, because of vomiting, have acid attacks. So there's a lot of acid in the mouth that causes erosion of the teeth, as you can see in the bottom left. A lot of abscesses, compromised immune system. So you see a lot of infections that you would not see in a normal mouth. And acute presentation, the final slide picture on your right, which is a more acute form of presentation, which is cellulitis and abscess. And this can result in really a lot of hospital time, dental-related hospitalization, and a lot of burden on health service. Next one, please. So there is a two-way relationship. So that because of the use of methadone, there is an impact on oral health, but at the same time, poor oral health results in a lot of systemic psychological impacts, as well as on quality of life. They have a lot of systemic illnesses because of increased bacteremia. there is morbidity, huge morbidity and premature mortality that has been shown with poor oral health. Obviously, loss of teeth, loss of functioning teeth, and as well as front teeth results in embarrassment, lack of opportunities to get employment, limited social interaction, and that can exacerbate the depression and ongoing existing mental condition. And this is one of the quotes that a patient that Shivani is going to present on did say about the impact of oral health on her ability to have a normal family life. So it has a huge impact, which is not really visible in the first instance. Next slide, please. So people with substance use disorder may not address their oral health problems unless they access some of the services with the drug health service, and that's shown to be the most common thing. They may just hold on to their pain. They will not access dental services, but they do access drug health services, and that's a really opportunistic time for us to for the drug health colleagues to ask about oral health, identify any oral issues, and help them in providing them timely access and referral to oral health service. So hence we are here today. We really feel that our colleagues can play a huge role in early identification and intervention of oral health problems, and that can also help improve their quality of life as well. So it is a holistic care if we are incorporating oral questions or dental disease related questions in the screening or initial assessment. And this was recognized by our service, and we have worked very closely with our partners, drug health partners in Canterbury Clinic, along with the oral health clinic that is led by Shivani at Canterbury, and developed this collaborative model of integrated care, which she will expand in the coming slides. The only thing is that in public dental services, we have a criteria of who we can see. So obviously, we can only see patients who reside in Sydney local health district. They have to have Medicaid card and one of the concession cards. And at the moment, we can only offer managing their urgent treatment. We do put them on wait list, but they do go on a priority wait list, which is shorter than other wait lists. So once they're off wait list, then they can get comprehensive care. But if they're not eligible for public dental, there's option of private practices as well. Obviously, there is a factor of accessibility and cost. Next slide, please. So I will hand over to Shivani, who will present the case that had one of the patients who has come through the oral health drug health pathway. But before I hand over, if there's any question in the chat, I'm happy to answer, or any comments that people would like to share. No? Okay. I'll hand over to Shivani.
Thank you, Shilpi. So the case that I'm going to be discussing is about a 34-year-old Caucasian female. She has a history of illicit substance use, street substance. Currently, she's on the methadone program at Canterbury Drug Health Services. She's a social welfare recipient, has a complex personal history in terms she has been in foster care since the age of 4, since her mother was an IV drug user. So she's also has 3 children under 4 years of age, and has been experiencing toothache for several years, and also has dental phobia, attended a dental clinic when she was 8 years old and got traumatized. So she hadn't seen a dentist since then. And with the pathway that we've got, which we have piloted at Canterbury Hospital between the drug health and oral health services, we developed a collaborative model of care, and this was implemented in January 2023. Next slide, please. So I'll just basically give you an outline of what the collaborative model of integrated care was. This was developed to facilitate and assist the substance use disorder clients to access the public dental services. As Shilpi said, our criteria is quite limited. However, most of the clients, drug health clients that attend the services met the eligibility criteria. They had some sort of the pension card or a healthcare card. So they were able to be referred. So what we did was we created a screening tool and requested the drug health service staff to use these 2 questions. So, and it would be an ideal thing for all the other healthcare services to be using these 2 questions. The first one being, do you have any toothache, broken or loose teeth, or difficulty chewing? This actually tells us about what challenges they would be facing. And as Richard has mentioned, vomiting is one of the ones that actually came to mind. And when clients do vomit, what happens is the enamel gets destroyed, and that causes more caries quicker. It's much more quicker than in the general population. So the second question is about having any swelling of mouth, dental trauma, injury, difficulty opening mouth. This is basically for acute care. And as you'll see on the OPG that I've got at the next slide, this was one of the cases where this was quite significant. So the key features of the model of care that we've got is that there were site champions from both the services. So it was a multidisciplinary approach. So the drug health services, the doctors in the drug health services, as well as the RNs and social worker were a part of the service that actually asked these questions and then organized a referral to the Canterbury Dental Services via an email. So that will expedite the process of providing an appointment for the drug health clients. And we also provided appointment reminders from both the services. So, and we also, what the drug health services also did was escort the clients to the dental appointments. And the communication pathway was enhanced through this collaborative care because we started communicating. I think dental being in its own silo for so many years, it was quite an eye-opener to be able to work with the other colleagues from other health services. And it has been quite rewarding for both the services. Next slide, please. So this is the OPG that we actually got. Apologies, the right condyle is missing. This was it was a very difficult process to get any X-rays from this client. So what the drug health staff did was took her to a private radiology clinic and got the best radiograph they could do. And so once she presented to our clinic, as you can see, there is active caries present in the, on all quadrants. But what the patient's main concern, she knew that she has been living with a lot of pain since 10 years or so. But she never had the courage to actually attend the dental clinic. So once she decided to have a chat with the social worker, they actually referred her through the pathway, and we were able to then go from there. Next slide, please. So in terms of the problem list that we gathered after the assessment phase was that obviously there's multiple broken teeth, the posterior teeth, which is a sign of difficulty in eating. There was active caries, and this is what could lead to facial swelling that Shilpi was talking about in terms of hospitalization. She also had toothache. There was parafunctional habit as well. And obviously she was suffering from dry mouth, and there was difficulty chewing. So in terms of management, obviously due to the dental phobia, the patient was quite hesitant to attend, and yes, there were a few appointments that was missed. But at the initial appointment, what my aim was to ensure that we built a rapport with each other so that she would be able to come in. So there was basically a non-judgmental approach to this, because I think she also had the idea that any dentist looking into her mouth or anyone looking into her mouth would actually judge her in terms of oral hygiene. So once we started building a report, and so the initial appointment was basically doing a diet analysis, having a discussion about oral hygiene habits, focusing on preventive measures to control caries. Yes, I know all quadrants had a lot of decay, but we didn't do anything drastic at the first appointment. And what we did was we also asked the patient what she wanted us to do for her. So instead of us telling her, we got her to actually tell us. And if you can see on the radiograph, that little chip on the lateral incisor is what her concern was. So she actually said every time she smiled, that was what she felt that everyone was looking at. And it was quite an issue for her aesthetically. So at the second appointment, we actually restored that. And I think just doing that and ensuring that when we used anesthetic, it was quite a traumatic. And as you can see in the photo, we've got the registered nurse from the Drug Health Services actually holding her hand while we actually were doing the filling for the patient. So that was quite good, because once we were able to develop a bit of trust within the patient and the dental team, it was quite easier to manage the patient. Then after that, we then decided to do surgical extractions quadrant by quadrant, in that it was a more longer process for that. However, this was something that the patient was more comfortable with. So once we control the caries, and what we've seen with the client is that she actually changed, and she was able to come and make an appointment independently. So this was quite a good progress for this case that we did. And in terms of a management, continual management phase is basically reiterating oral hygiene habits, because we don't want the clients to relapse and then go into habits where it's harder to maintain their diet. So this is what we're doing. And in terms of replacement of the missing teeth, because we did take out quite a few teeth for this patient, she's on a waiting list. And as Shilpi has mentioned, the waiting list is shorter. So once she comes off it, we actually offer dentures though. And if it was private practice, the treatment that would be offered is more complex and costly. So it would end up being more than 40,000 in terms of the treatment that they get provided. So this is something that we can do with the public services and manage it with dentures, but that will maintain their normal function. So I think I'll hand it over to Shilpi to discuss the considerations and challenges that we faced.
Thanks, Shivani. So this is our last slide, and I just wanted to highlight that, yes, treating these patients is not simple and straightforward like our conventional patients. These patients are quite complex. They have high medical needs. They have polypharmacy, but also they have challenging psychosocial factors impacting their behavior and their ability to understand what the processes of treatment and also participate in the treatment that they receive. So the biggest challenge is engaging them with services. They have a high failure to attend rate. And that is one of the reasons that private practices may struggle to see these patients, because if patient is not coming, that is at loss of patient time and money, and it cannot be something that's sustainable. And it's sometimes hard for us to sustain as well, because it's a model and we are public services. We are able to take a fair bit of, inconsistencies in their attendance. But I think that is one of the challenges for the dental services to manage these patients. Plus, they need a holistic approach. They cannot be treated in isolation. We need the bigger team to help overcome the initial phobia, inform them about the importance of getting their dental treatment done, bring them up to speed with the modern dentistry, that the treatment provided are far more comfortable. They're not as painful. And once they are there in the dental service, then the dental team is able to, as Shivani highlighted, build rapport with them, help them get over their initial phobia, and then take it at their pace and treat them one by one. But for patients, for these drug health clients, I think the integrated care model of treatment is the way to go, because without that, we will have challenges in getting them to a surgery and maintaining, seeing them subsequently for remaining treatment. But also patients do need that extra support for taking that initial step. And that is what the model of care is able to provide. Thank you very much.
Thanks, Shilpi and Shivani. Yeah, there is a comment. Someone said, inspiring interdisciplinary model. Any advice on how to replicate the Canterbury model in another location? And someone also is curious how to replicate this in regional areas as well.
Yeah. I'll go first, and then Shivani can add, if that's okay, Shivani. I think we have tried to replicate the model in Freudian clinic as well. It's just starting now, but again, it is a similar setting where it's a community clinic where both the services are co-located. If we have to replicate that, we really need champions from both ends. I think the dental team is quite keen because they know that these patients will have a fair bit of work that is required, and they can handle the work as well as managing the patient as far as the dental procedures are concerned. But we need a champion at the other end to bring up oral health, because oral health is something that's missed. I don't think it's asked at all unless patient brings it up, or patient is unable to concentrate because they have this acute dental kind of pain, and only then dental is brought up. So if it is part of regular questions and early identification, when patient is not in pain, you get subsequent appointments to build their confidence, and then bring this contact with the oral health partners close to the clinic where you are, and just have a chat that these are the patients and what are both services willing to do for the patient, because just sending a referral is obviously not enough. As you can see, they needed some hand holding, some kind of support. Some of them can't leave their children. They need somebody to look after them while they are being treated. So I think a multidisciplinary holistic planning session is required initially. Maybe the dental team can come and meet the patient in a setting which is more comfortable for them, just to get them to know who the person is. When they go, they will be seen by, and then probably take it from there. Rural is a bit of a challenge because of the distances that patients have to travel, and also lack of opportunities of easy referral for complex cases to specialists. So that could be a challenge, and hence undertaking this intervention early on when they are not in acute case where it's not so complex that it requires specialist services would be the way to go. So keeping them in a state where they can have small treatments done quickly that can be done by the dentist at the chair side probably is a better approach. Shivani, do you want to add something?
No, I agree with what you said, Shilpi. I think it's basically having champions. So both services have to be willing to come together, and having executive teams that are willing to provide us, like as a dentist, I was provided enough time to be able to do this. So I think time factor as well, and having a support from the executives are quite important in achieving what we were able to. So that's one of the most important things, and having champions from both sides who are willing to go above and beyond to help the clients. I think that's the most important thing.
Thank you, Shilpi and Shivani, for that presentation, and also to Richard. These are their emails in case you want to reach out. They've also sent me links to resources that I will include on the OTAC website when I upload the slides and the recording. And just some general resources, SACE script. There's a link to your local AOD services as well as for DASAS. And I'd just like to thank Dr. Richard Hallinan, Associate Professor Shilpi Ajwani, and also Dr. Shivani Chandra once again for this really wonderful and comprehensive presentation. Our next webinar will be on the 20th of August about the updates to the long-acting injectable buprenorphine guidelines.